speaker for tonight. Okay.
Hello, magandang gabi. Thank you, Rod. So the World Health Organization declared monkeypox a public health emergency of international concern in July. And just 4 days ago, monkeypox was declared a public health emergency in the United States. There's been more than 27,000 monkeypox cases reported across 87 countries. And I think it'll just be a matter of time for monkeypox to have a significant impact here in the Philippines. We are fortunate tonight to be with two distinguished resource persons who can help shed light on this very important concern. First, we have our main speaker tonight, Dr. Kenneth Mayer. Dr. Mayer trained in internal medicine at Beth Israel Hospital and in infectious diseases and molecular epidemiology at Brigham and Women's Hospital. He was a clinical and research fellow at Harvard during that time. As the founding medical research director of Fenway Health, he created a community health research program that has developed an international reputation for its capability to conduct community-based research. He is currently a professor of medicine at Harvard Medical School, a professor in global health and population at the Harvard T.C. Chan School of Public Health, and is an attending physician at Beth Israel Deaconess Medical Center. Starting in 1994, he has been a site principal investigator of NIH-funded clinical trial units, focusing on biobehavioral HIV prevention research. He is also a member of the scientific leadership of HPTN. He has co-authored more than 1,000 peer-reviewed publications, co-authored the first text on AIDS for the general public, and has co-edited 5 academic texts. He has served on the national boards of AMFAR, HIVMA, and GLMA, and was a member of the CDC HRSA HIV/AIDS Advisory Committee, and a member of the Governing Council of the International AIDS Society. He is an editor-in-chief of the Journal of International AIDS Society and serves on the PEPFAR Scientific Advisory Board. Ladies and gentlemen, from New York City, without further ado, Dr. Ken Mayer.
Thank you, Dr. Kate. Can you hear me okay?
Yes, you're coming along well.
Wonderful. Mabuhay, everyone. I'm sorry not to be with you in Manila. I've spent many wonderful times in Manila for many years. I've worked with people at PGH and RITM. So it's great to be in touch. And I salute SHIP for pioneering this international community education. And I want to thank my colleague, Dr. Bruce Agins, for arranging the invitation. So we'll see how the miracle of modern technology works. We're going to try to share my screen. Can you see my slides?
Yes, we can.
Okay, and you see them as an individual slide, right?
No, yeah, there you go. Okay, this is perfect.
Good. Okay, let's hope it advances. So I have a bunch of slides, and we only have an hour, so I'm going to go very quickly, but just to set the stage for you. So first of all, monkeypox, it's rare. In Africa, there have been people who have died from monkeypox. Now, globally, there have been 10 people, but as you heard from Dr. Kate, there also have been more than 25,000 people already identified. Monkeypox is a cousin of the smallpox virus. It's in the family called orthopoxes. We don't know which animals carry it, but we know several different mammals, and there actually was an outbreak due to prairie dogs imported to the US a few years ago. It can be spread by respiratory secretions, but that's not very efficient. So you'd have to be very close to somebody for a sustained period of time. The main contact is skin-to-skin contact, but it also can be interjected mucosally, so people can get monkeypox in the throat and in the rectum, and that's a big problem for people having sexual activity. And in Africa, there have been cases associated with fomites. That means shared towels or shared bedding. We've not had reports of that yet in the current outbreak. That doesn't mean that it can't happen. So there were cases before the current one. In 2003, there were these small mammals imported from Ghana, and this was mainly in the Midwestern United States. In 2021, there were 2 cases that were unrelated, people coming in from Nigeria, and there were cases in other parts of the world, in the UK, Singapore, and Israel had similar kinds of sporadic outbreaks. But what we are seeing now is sort of classic monkeypox, but really spread quite widely. So these are, I'm going to show you a bunch of pictures. I apologize if they seem gross, but I know that some of the people in the audience are clinicians. So you can see what these vesicles may look like. These are photos taken from the original outbreaks in West Africa, in Nigeria, and in Cameroon. But what's happened recently is different. So there were first some initial cases in the United Kingdom, and they found that they thought they were travel related. There were two events, one in the Canary Islands and one in Antwerp in Belgium, which were parties where people had lots of contact with each other, not all intimate sexual contact, but close body contact. And people who attended those events were associated with some of the first cases. In the United States, actually, the first case was identified in Boston. This was somebody who had traveled to Canada, though the states in the US, the more populous states such as New York and California, now have the largest number of cases. This first case began as an anogenital rash. There were these vesicles, little fluid-filled bumps, which became pustules. In other words, they had inflammatory cells, and some of them had secondary infection. OPX is orthopox, and this is a generic test, but it only can be done at reference laboratories, and the person did test positive. At this point in the United States, there are over 7,500 cases as of Friday. Most of the states in the US have had cases, and as you heard, there are well over 25,000 cases in more than 80 countries. This just gives you a sense of the kinetics. It doesn't mean that the epidemic is slowing down. It just means that reporting lag for the more recent cases. So look at June 23rd, and that really gives you a sense of how rapidly this is spreading. So of the first cases in the United States, they were in the mid-30s was the median age, but the range is quite wide. The majority of individuals had male sex at birth, and majority identified as cisgender man having sex with men, but there were a few females as well. There were a few transgender men as well. In terms of the clinical symptoms, most people in the early cases had some kind of rash, but the rash could be only one lesion or it could be multiple lesions. The lesions could be at different phases of development when seen examined on a person. The rash could be scattered or diffuse. Sometimes one body sites, some people only had rectal lesions and pain, or lesions mainly on the face. Usually pain would bring people in for the rectal symptoms, but some people would notice the rash. Some people, but not all, would have prodromal symptoms, which could be fever, swollen glands, lymphadenopathy, but this didn't happen in all patients. And many of the cases were in conjunction with other sexually transmitted infections. So for those of you who provide sexual health services, this is important to keep in mind. So these are some of the key points, clinical points of some of the lesions. They tend to be firm, they tend to be deep, they tend to be well circumscribed. They often are painful, itchy. They sometimes have umbilication, which means that there's a sort of a central area surrounded by a wider rim, as you can see in Exhibit A. Generally, they tend to be small, a few millimeters. They can progress rapidly through stages, and you can see the different stages. You can see the initial papules, which would be red raised bumps, and then the pustules, and the pustules then break into ulcers. And you can see that all on an individual person. So this just gives you a sense of what some of the different lesions can look like. They can be present also on the palms and on the soles. Here you see some additional lesions. And so anybody who has anything that looks like that, even a single one, certainly you want to think monkeypox in that regard. So the CDC has provided various kinds of guidance. You want to perform a thorough examination so you identify all the lesions. You want to obtain swabs if there's any index of suspicion. And again, I don't know what the feasibility of doing testing is in the Philippines. I would imagine that a central laboratory like the Research Institute for Tropical Medicine, RITM, might be standing up this activity, but I don't know that. So I would be interested in what Dr. Dusty Roman has to say, and others. Remember that sort of identifying one sexually transmitted infection does not rule out infection with monkeypox. So people could have more than one sexually transmitted infection. It's important to understand clusters. The CDC is sequencing the genetic material of the monkeypox, but so far, the strain that is currently present seems to be identical to the strain present in Africa. So we think this is just getting into a population that may be susceptible, and not that this is a different virus, but there are a bunch of different studies underway to better understand this. And certainly there are important questions like how many people have asymptomatic monkeypox, or can you be transmitting for long periods of time? And because some people go from being asymptomatic to a sore throat or rectal pain and then developing the lesions, certainly early symptoms can be associated with transmission, but we don't know if there's a large reservoir of asymptomatic people. That is being studied at the present time. So I want to talk a little bit about clinical recognition and then talk about countermeasures. So the CDC provided a very nice example that I think is helpful. So this was a 26-year-old Latino man who had sex with men. He came to a public health clinic. He had no concerns. He had a telemedicine visit. He was being seen for PrEP, and he noticed that he had some lesions the morning after his telehealth visit. So he was self-collecting specimens for STI. He mentioned this rash on his penis. He said that he had had sex with 3 men at a sex party in late May. He didn't know if any of the partners had recent travel. He did not have international travel. He had no fever, swollen glands, or fatigue. When he underwent exam, he was uncircumcised. You can see these lesions on the penis. One might think molluscum. They were painful, so one could think potentially a serious herpes infection. There was no swollen glands in the groin. He was tested again for HIV. He was had a culture for herpes done. He was started on empiric treatment for herpes, but then people said, well, we're starting to hear about monkeypox. Maybe we should look for it, but that wasn't done initially because there were no prior symptoms, and it was only 4 days between the sex party and the onset of symptoms. So he came to the clinic to reassess, and he agreed to be abstinent. After several days, though, you can see the lesions evolving and becoming true papules. And so they did further testing. They found that he did not have syphilis. His test for herpes was negative. His tests for gonorrhea and chlamydia were negative, though he did have, except for a urine NAT test was positive for chlamydia. So he did have chlamydia infection in the penis, but this is not consistent with chlamydia. So it looked like he had more than one acquired infection. He started developing symptoms where he had lesions on other parts of the body. He then developed fever and he had fatigue and decreased appetite. And he then learned that one of his partners at the New York City sex party, lives in Toronto, was symptomatic and received a monkeypox diagnosis. The pertinent history was that he had had 10 partners in the past 90 days. He reported using substances. He met people online and engaged in receptive and insertive anal and oral sex and had prior sexually transmitted infections. So the public health individuals had to also think about who else might have been in contact with him during this potential incubation period. He subsequently developed a sore throat, and he had lesion in the right oropharynx, which was painful. He had a lesion that developed on his chin. He had these lesions on the penis. So the lesions were swabbed then for monkeypox testing. He was also given doxycycline because of the chlamydia diagnosis. He was asked to call the clinic for follow-up. Subsequently, he had a partner that came in for evaluation. They were together 1 day before his symptoms developed. The partner reported 3 male sex partners in the past 90 days, including anonymous or pseudo-anonymous, meaning knowing people only from their online handle, engaging in receptive and insertive intercourse, and had prior history of chlamydia. And the partners then developed lesions 6 days after the initial person developed lesions. These developed on the chest and on the trunk. There was one small one on the buttocks, no swollen glands. So you can see that the partner also was given doxy because of the exposure to chlamydia, and also had a presumptive diagnosis of monkeypox. All 3 of the patient and the partner's lesions tested positive, so they both had monkeypox. The lesions continued to increase. He had problems urinating. He had to go to an emergency room, treated with opioids and other anti-inflammatory agents. He was able to subsequently void after the pain was controlled, and he was discharged home with pain management, an additional week of doxycycline, because some of the lesions clinicians thought might be associated with cellulitis. The partner came to the clinic for post-exposure prophylaxis with vaccine. His lesions were resolving, and this partner had a negative diagnosis and rapid resolution, so probably had folliculitis. So I went through this very quickly, but just to show you some of the things we have to keep in mind with monkeypox. Really important to get complete sexual histories, especially if there's symptoms that suggest a sexually transmitted infection. I believe that this is something of a semantic discussion about whether this is sexually transmitted or not. In other words, there are behaviors that we don't consider classic sexual transmission that can transmit monkeypox. In other words, you don't have to have insertive penile activity with penile anal or penile oral activity to transmit monkeypox. Body-to-body contact can transmit this virus, but certainly the virus can be particularly nasty if it gets into the throat or gets into the rectum through sexual contact. So it's sexual behaviors that are associated with transmission. The rash often begins in mucosal areas if there's potential exposure. The patient was able to take photos. So because somebody comes in the clinic with pain or with one lesion, this process can evolve. And rather than have people come back to the clinic if there's a presumptive diagnosis of monkeypox, people can send photos to the clinic. In this case, the prodromal syndrome, which prodrome usually means symptoms beforehand, in this case, the symptoms began after the onset of the penile lesions, and there wasn't swollen glands, but certainly there can be a classic prodrome and there can be swollen glands. So there can be atypical presentations, I think is the take home here. Also, concomitant sexually transmitted infections. Don't think one sexually transmitted infection. People who are in networks where they may have more than one partner, particularly anonymous partners, particularly if they're meeting people in large sex venues like sex parties, may acquire multiple sexually transmitted infections, including monkeypox. And we have to keep in mind that incubation periods can vary greatly. So there are some countermeasures that we have. There's a vaccine called Jynneos, and there's a vaccine called ACAM 2000, and there's several treatments. And Tocilizumab, which is called TPOXX, I'll tell you more about in a minute. So Jynneos is the preferred vaccine in the United States, and I'll show you a comparison with ACAM, why it's preferred. It's a live virus that's a modified vaccinia, which is smallpox is the name for vaccinia. It's made by a company called Bavarian Nordic, so that's why it's called modified vaccinia anchor of Bavarian Nordic. It's attenuated, so it cannot replicate, cannot multiply, but the body thinks of it as an active virus. It has several names around the world. It was licensed by the Food and Drug Administration in the US several years ago, and it's indicated for prevention of smallpox and monkeypox in adults. And the CDC is developing an expanded access protocol. ACAM 2000 is the older vaccine. It's a live replicating vaccinia virus vaccine. The fact that the virus can replicate is good and bad. It's good because it causes a very intense immune response. It's bad because during the period of time while there's a scab being developed on the shoulder where people are vaccinated, that's a period of time where somebody might be able to transmit the virus to somebody else. So that is a concern. But it is also Food and Drug approved for smallpox and has been used for monkeypox. Here's a table that compares the two different vaccines. And really, the important things to understand are that the ACAM 2000, the one big advantage is it's a single dose because it's so immunogenic, because it has such a strong immune response, whereas the Jynneos preferred vaccination schedule are 2 shots 4 weeks apart. There's a big debate, and there's finally some studies underway to say how much of a benefit you get from a single vaccine, because given limited vaccine supplies, we think it's better to get more people at least 1 shot. if we don't have enough vaccine to give everybody 2 shots yet. But there's really a push to get this JYNNEOS increased. And the big issue, there are adverse cardiac events, myopericarditis, and this is about 1 in 500, a little over 1 in 500 in people with the ACAM 2000 vaccine. There have been rare cases that have been thought to be reported with JYNNEOS, but it seems very rare and very unlikely. So the JYNNEOS is thought to be a safer vaccine than the ACAM 2000. And then the fact that the ACAM 2000 is a live virus that can replicate, we don't want to give it to people who are immunocompromised. And that would include people with HIV, particularly people whose viral load is not suppressed or who have low CD4 counts. So we don't want to be giving one vaccine to HIV, to people who are not living with HIV and another to people living with HIV. So that again is another reason why the JYNNEOS is a preferred vaccine. We talk about pre-exposure prophylaxis and people who are likely, like laboratory workers who are doing a lot of work with orthopox viruses, might be people who might be getting the vaccine as pre-exposure prophylaxis. Also, people who are at high risk. There are counterindications, as I mentioned, and immunosuppression is the main one. That's why I put it in red for the ACAM 2000 vaccine. There's really no counterindication to the JYNNEOS vaccine, other than there are components of the vaccine. So if people have a history of allergy, that's important to take good history. But generally, the JYNNEOS is pretty easy to administer and well tolerated. So in the US, there is surveillance going on. There's some attempt to do contact tracing. And then there's post-exposure prophylaxis. So people who know that they've been exposed are candidates for the vaccine. But as vaccine becomes more available, more jurisdictions are making available to individuals who are high risk, who have who are not in a monogamous relationship, a mutually monogamous relationship, for example. High percentage of contacts, though, can't be identified. So this is another reason why community vaccination, if the vaccine is available, makes sense, because not everybody knows if they've been exposed to monkeypox. They just know that they've been to a party or they met people online, but they may not know their status. So this is really the move towards making the vaccine more available to the community. But there is a limited supply, and in the US, clinics like ours at Fenway Health run out of vaccine very, very quickly, and this is a problem. So the CDC is constantly in the position, because they control the vaccine supply, to determine which jurisdictions get how much vaccine, and this is not optimal. There is a scaling up now of the vaccine, but we really need to keep pushing so this doesn't become more of a global public health emergency. So there are some treatment considerations. There are many people where monkeypox is annoying, but it's not necessarily a serious problem. In other words, they may have a few lesions, they may be on the trunks, they may not be visible to others if people wear protective clothing. But there are other people who are miserable, who have extreme pain, have lesions in various parts of the body, and need treatment. So there are some people, rare cases, that may have hemorrhagic disease. Sometimes there are lesions that can be next to each other and keep growing, and that can be a problem. People can get secondary bacterial infection as well. There are rare cases where the virus can affect the brain. Those are people who need treatment. Certainly people who are severely immunocompromised, somebody who has uncontrolled HIV or has a malignancy as a candidate for treatment. Younger age groups can do very poorly with this. This can affect pregnancies as well. And people have a history of skin allergies, atopic dermatitis. This can be a problem. And certainly if the rash or the lesions are near the eye, it can affect vision, and therefore that is an emergent situation. If people have such pain that they can't void, they can't defecate, that's another concern for treatment. So there is this medication, tocoviramate or TPOXX. The problem is that it's not fully available commercially. So therefore, there's a lot of paperwork that has to be filled out and has to be administered by trained professionals and has to be obtained from the CDC. There's a national stockpile. So this is also limitation. There are other approaches, but there's IV immune globulin, vaccine immune globulin. There's very little of that available and not widely used. There are drugs such as cidofovir and bisodofovir that can be used, but they tend to have lots of side effects, affect kidney function. So they're not preferred, but sometimes may have to be used if the TPOXX is not readily available. I mentioned these others. And again, some others, there's trifluridine, but again, these are not things that are generally available. The TPOXX is what we've been really relying on in the United States. So that really brings me to the end of my comments, and I think I can unshare. And happy to take any questions that you might have.
There you go. Thank you very much, Dr. Ken. Before we proceed with our Q&A, we'll have first a presentation from our reactor, of course. And before that, let me just share with you some of the things that I was able to catch based on the presentation of Dr. Mayer. One of the important lessons learned is that it is important to have a complete sexual history of the client, that there is a vaccine and treatment that is available, although the supply is limited. And as to vaccine, there is what we call pre-exposure prophylaxis that is really intended for those who are at risk, like the health workers. And there's also this what we call post-exposure prophylaxis. And then in the US, in terms of their outbreak response, it is important for them to do surveillance and containment or isolation. And as to vaccine strategy, when they rolled out their vaccination, of course, their priority is always the areas or those areas with high number of cases. So it's like prioritizing which one should be vaccinated first because of the limited supply of vaccines. And then, of course, when it comes to treatment and considerations, particular treatment considerations is being given, of course, for those individuals who are immunocompromised, for those individuals who have severe disease. But one thing that we need to be how should I say it, happy about it is that there is an available vaccine and treatment for this. Okay, Doc Kate, would you like to add something else or some other ideas?
That's okay, Rod. I think you covered everything in a succinct summary. Thank you for that. We can now proceed to Dr. Roman's reaction.
Okay, thank you. So now, I'll be introducing our reactor. Okay. Let me just share my screen. Okay, so there you go. So our the next person who is going to speak is going to react about the presentation of Dr. Kenneth Mayer. At the same time, he's also going to give us some updates and bits of details when it comes to the very first case of monkeypox in the Philippines. So the next person to talk, he is a clinical associate professor at the University of the Philippines. He is also a medical specialist 3 and currently the head of emergency room of RITM. He has a master's degree with distinction in tropical medicine from the university in Japan, Nagasaki University. He is a diplomat and fellow of the Philippine College of Physicians and at the same time of the Philippine Society of Microbiology and Infection, or PISMID. And he is currently the board secretary of Philippine Society of Microbiology and Infectious Diseases. Among his specialization is, of course, infectious diseases, internal medicine, at the same time, tropical medicine. So without further ado, let us all welcome Dr. Arthur Desi Roman. Doc Desi.
Hello, good afternoon everyone. Hindi pa naman masyadong umuulan dito. So I think we'll be able
Great.
to go home safely, everyone. Uh, I will just give a short reaction to the presentation of Dr. Ken. All right. So the features of the first monkeypox in the Philippines, according to the release by the Department of Health, are the following, di ba? A middle-aged male with a travel history to European countries and engaged in activities that might have put him at risk for close contact with many individuals. And this is the primary mode of transmission of monkeypox. And this was detected through consultation with a local healthcare provider already and not at the ports of entry. Okay. The presentation of this patient was very similar to the reported cases in the US and in the European countries. And this would include an incubation period of around 16 days, and there were few lesions only, and the prodromal phase was very mild. There was some history of anal bleeding. The classic progression of the lesions followed what is prescribed or described in the book, beginning from vesicles, following and developing into umbilicated pustules. And the symptoms of the patient was actually or were mild enough to be discharged and allow him to complete home isolation. So these are some of the good things that we were able to identify in this first experience that we had. First of all, we were quite happy that the PCR protocol for monkeypox DNA detection has been set up already even before the first case was identified. Okay, and we already have guidelines for specimen collection, transport, and processing. And this was done by RITM, and the PCR for monkeypox testing currently is still publicly funded. Okay, the referral center, for example, RITM and San Lazaro, are both ready for case management and isolation of these cases. The patient was cooperative with good health-seeking behavior, and there was a contact tracing mechanism in place already. And the additional good news was the number of close contacts identified for this patient was actually very limited. Okay, so some of the issues identified during the first case are the following. Number one, we realized the limited referral centers. Okay, some of the healthcare facilities, both government and private institutions, are not yet prepared at that time for the management and handling of monkeypox cases. And so patients, such as our first case, might not have the autonomy to choose where to consult. Okay. Next, there are issues on privacy and release of information given that this patient is the first case, so we were very much careful about this. Next, we focus on patient education. Of course, we had to talk to the patient about the expectations about contact tracing in the next few hours, who will contact him, and what are the things that he will be asked about, who will do the follow-up and monitoring of the patient, and of course, the advice on how to prevent the spread of the infection as he continues to isolate himself at home. And of course, on the part of the Department of Health, the proper risk communication to the public. And now here are the current challenges that I have identified. Number one, we still have limited testing centers. Currently, it's only RITM that's doing the test. But I know that there are ongoing efforts to expand this testing to other government centers. Number two, the frontline healthcare facilities might not have space for isolation. Of course, the tertiary and secondary hospitals, because of COVID-19, would have identified isolation areas already. But there are other institutions that might not have any. For example, the doctor's clinics, the standalone doctor's clinics, the social hygiene clinic, the sexual health clinics. Of course, these are just small spaces and they may not have these areas where they can temporarily place monkeypox suspects in isolation. Next, Specimen collection can be tedious. It requires the use of personal protective equipment, the use of Dacron swabs, and of course, as I've said earlier, identification of an isolation area. Specimen transport after you've collected them needs close coordination with the local epidemiology and surveillance unit, and this is to be shouldered by the sending facility. Okay, there is currently no access to investigational drugs and vaccines here in the Philippines, unlike in the case of Dr. Ken. The diagnostic tests for other differentials, for example, PCR for varicella, are not readily available or expensive, or it will take time. Even if they are available, sometimes it will have running times. And of course, if you get your specimens a few days before the running time, then you might have to wait until after that running day. Next, of course, we want increased awareness. This is always good, but sometimes because of the anxiety, there's always the risk of over-testing, especially of patients with alternative diagnosis already. And we are tempted to test for monkeypox just because we have an anxious patient or an anxious healthcare provider. So what we need to do really is to increase the skills of our frontliners in diagnosing common skin disease conditions and in ruling in or ruling out monkeypox. And there's a need to link dermatologists and infectious disease specialists to other frontliners who might not have the confidence to diagnose and treat the skin conditions. And finally, balance has to be achieved between identifying and reaching out to the affected population. At this time, it's the gays, bisexuals, and men having sex with men versus us creating stigma and discrimination among this group of individuals. With that, thank you very much for your time.
Thank you, Doc Desi. Okay, so let's just have some summary. So what is very important that we're able to catch up is that indeed we have some challenges because we have limited isolation areas, limited testing centers, and limited referral centers. But what is good is that despite of this limitation, we have a designated referral center, particularly our ITM in San Lazaro, who are ready to provide care and management for clients who might be affected by monkeypox. And then another good thing is that we already have established the PCR protocol for the monkeypox. Okay. So those are some of the things that I was able to catch from the presentation of Dr. Desi. And of course, we are lucky enough that as of now, we only have one who has been reported to have been affected or infected by monkeypox. So this time around, we'll proceed with our question and answer. So I'd like to seek the assistance, of course, of Dr. K to help me moderate this one for the question and answer. Okay?
Hello, thank you, Rad. We have received some questions, and why don't we jump right into it? I would like to direct this question to Dr. Mayer. First, coming from our Facebook comments, how long is a person with monkeypox contagious? Can you make me unmute?
Sorry, yes, I was on mute. Thank you. It's a great question. Certainly, if somebody has skin lesions, they have to assume that they can be transmitting the virus until the skin lesions are healed and there's normal skin where the lesions were. So that would be one benchmark. It may be trickier when the lesions are not easily visible, like in the rectum of the sore throat, but certainly we think virus can be shed over a period of weeks. So certainly several weeks would be the protocol to avoid intimate contact with other people.
Thank you. Now, Ken, regarding that, the CDC has released certain do's and don'ts for sexual practice. And one of those things that I did see there was you may have sex with clothes on. Now, I would like to ask if this is something that you also encourage, and corollary to that, how do you reconcile this with the recent recommendation of WHO to actually have condom use as a mode of protection from monkeypox as well?
Yeah, no, these are very important questions, and we don't have perfect knowledge. I mean, the first issue is in terms of sex with clothes on, that makes sense if both individuals are not known to have monkeypox or any symptoms or lesions consistent with monkeypox. So we have to just be pragmatic because this virus can be introduced in different places. So if somebody doesn't have skin lesions, they're fully clothed, but they have a sore throat, they might be potentially, because of the potential for monkeypox that could transmit. So obviously, no sore throat, probably kissing is okay then. But because we know that this virus, if it gets from the lesions to clothing or to bedding, the virus can persist there for a period of time. Wearing clothes if somebody is actively shedding virus would not necessarily be protected. But if both parties have no symptoms, the likelihood that they're shedding virus is low, and therefore clothes will offer some protection. In terms of condoms, condoms will protect from intimate exposure to monkeypox. So in other words, some of the cases deep in the rectum or down the throat are because of exposure to penis without covering. But on the other hand, if somebody has a little lesion on their skin and they're having body-to-body contact with another person, that could transmit monkeypox. So we have to be very clear about what kind of protection each harm reduction intervention can offer. So, nothing is perfect, but everything is about reducing one's risk from being exposed to the virus.
Thank you so much, Ken. That makes a lot of sense. I'd like to throw this question now to Dr. Desi. Considering there is a shortage of the vaccine, as Ken mentioned, and maybe even the treatment as well for monkeypox, are we in the Philippines lobbying for access to these via our Ministry of Health?
Sorry, Kate, I'm not in a position to answer that question, but I know there are talks. I know that there are initial communication with other countries about the possible procurement of these investigational drugs and vaccinations.
Thank you. Ken alluded to this in his talk. Cidofovir is a possible alternative. Out of all the treatment options, I think this might be our closest one. Is this available in the Philippines?
I have tried to ask our nephrology colleagues if they are using cidofovir, but most of them answered they have no experience or they are unaware of any access to cidofovir either.
Okay, that's clear. So right now, maybe if we do have a surge of monkeypox cases, we could very well offer for now supportive home management, which then leads me to asking this of Ken. What are the recommended home management advice for monkeypox?
Well, first of all, if somebody lives with more than one person, to be very clear about who has contact with bedding or anything that touches the body of the infected person. This is not easily transmitted the way, for example, SARS-CoV-2, COVID-19 is transmitted through respiratory route. So there's no reason to have somebody in a quarantine house or quarantine hotel, but they have to be, preferably a separate room, preferably separate towels, separate bedding, and no direct body contact with other household members. So that really becomes important. And then, personal hygiene, because one of the biggest complications of monkeypox was for the vast majority of individuals at this point, more than 99% of individuals will resolve this infection, particularly if they're not immunocompromised in any way. They'll resolve it without major problems. But one of the big complications will be cellulitis, and sometimes cellulitis can lead to systemic infection where the bacteria from the skin can get into the bloodstream. So keeping the lesions clean is very important. So that's hygiene for each individual lesion. Bathing, keeping it covered if there's an ulceration, for example, so that you limit the amount of secondary infection that gets into the skin. Because eventually, these lesions they're very annoying. They can be quite painful for some individuals. They can be itchy, so you may need medication such as Benadryl just to decrease itchiness. But they go through a cycle, and eventually they will scab, and eventually the scab will fall off, and then there will be normal skin. So it's really a matter of the several-week process of waiting these lesions out and trying to minimize any kind of secondary complication.
Thank you so much. What about anything over the counter that we can provide? You mentioned some pain. Is the pain severe enough to warrant pain medications in your experience?
It's quite variable, and we don't understand all the factors why some people have a much worse course than others, but some people will have extreme pain, and particularly if the virus gets into the rectum, if the virus is right on the penis or other mucous membranes in the throat, that can be very painful. So if it's in the throat, for example, gargling, if there's lidocaine solution, gargling just to numb it can be helpful. Certainly lozenges, the kind of things we do for any sore throat, you would do very similarly. There's no counterindication to the usual kind of topical measures, and certainly again, managing by keeping the lesions clean as much as possible is important.
Okay. Oh, so really hygiene and cleanliness and keeping the lesions clean is very important. So I hope this is remembered by our audience today. Now, moving into the future, in case we do get our hands on Jynneos, is it safe for PLHIV, considering it's a live vaccine? Is there a minimum CD4 requirement for it to be given?
The Jynneos is safe for people living with HIV, which is the good news. It is replication incompetent. In other words, the virus can't multiply in the body. So it looks like a real virus. The body makes a good immune response, but the virus can't continue to shed or to multiply. So there's absolutely no reason why a person living with HIV can't get the Jynneos vaccine. It's the ACAM 2000 which is more problematic, where there is the concern because that virus, although it's a weakened virus, it can multiply. And the way that vaccine is given, it's a intradermal vaccine. So it's the kind of thing where, like the classic smallpox vaccine, where there's a lot of pricks on the skin. And so there's kind of a scab that forms. And during that period of time, the virus can be shed. And so the person is at risk of transmitting to others, whereas the Jynneos vaccine is not transmissible.
Good. And I heard that this was also given in the recent AIDS 2022 conference to some of the participants. So I'm glad to hear that, like, there might be countries which don't have access to it, but being sent, going to Montreal and receiving it is really good news, at least for some. Yes, Tessie?
I have a question for Dr. Ken. Dr.
Yes,
Ken,
please go ahead.
in the US CDC guidelines, there's a section there that says that you have to complete 21 days of isolation or until the lesions have healed. Does it mean that even if the lesions have healed for less than 21 days, the patient would still have to isolate to complete 21 days? Or as long as the lesions have healed, then we can discontinue the isolation already?
The preference is to go the 21 days. Most people will not have fully healed by 21 days, but in the case if somebody has, there's a very small, but we can't say zero risk that there might still be some viral shedding. So just it's sort of the abundance of caution. The preference is that the minimum isolation would be 3 weeks. So thanks for bringing that up.
And finally, Dr. Ken. Okay, did we lose Dr. Ken in the call? No.
I'm here.
He's still here.
Yeah, thank you.
Dr. Ken, may we ask what is the latest stand of the US CDC or our US colleagues as far as monkeypox being a sexually transmitted infection?
You know, again, I feel it's semantic. They don't call it a formal sexually transmitted infection because you don't necessarily have to have what we would consider sex, but it's an intimately transmitted infection. So sometimes we say that's a distinction without a difference. In other words, the reason why we say intimately transmitted, because if two people are naked and their bodies are rubbing up against each other, but they're not kissing, there's no penetrative penile sex, monkeypox could still be transmitted. So are two bodies rubbing up against each other sex or not? So that becomes something in the eye of the beholder.
Yeah. Thank you, doctor.
Desi, we have a phone-in question for you. Not sure if you have access to this information, but what was the treatment or management given to our first case, considering the limitation of our resources?
In the local guidelines, given that we don't have the vaccines or the medications, the antivirals yet, we just give supportive treatment for our patients, Kate.
All right, thank you so much. Just looking through our list of questions, making sure we don't miss any.
Yeah, there was a question, Kate, about the use of UV light for disinfecting, use of UV light for killing the monkeypox virus. I think it can be used as an adjunct for disinfection and cleaning, but in terms of cleaning, it has to, I mean, we have to follow our standard cleaning and disinfection protocols. Yeah, and everything in addition would just, in any additional strategies such as what the use of UV light or any other plasma sterilizer, then that should be good, but always in addition to the standard cleaning procedures.
Yeah, I agree with you. You know, I've not seen something about UV light in and of itself. I wouldn't rely on it by itself.
All right, thanks, guys. Okay, my next question. When is day 0 of the isolation period? Is it the onset of rash or any other first symptom?
It would be any first symptom, because this is such a variable illness, you know, and it's not going to be a perfect, perfect number no matter what. But in other words, some people will start off with the prodrome, but the case I presented to you, the symptoms, the fever and myalgias happened after the person first developed rash. So it's whatever we can attribute as a first symptom would be day 0.
All right, thank you. I hope that's clear, guys. Last 2 questions. We want to wrap this up by 8:30. For Dr. Mayer, could you please elaborate and describe further the takes in the 2 vaccines presented?
The take is when you have an evidence of immune response. So when we talk about the ACAM 2000, the take is that there's a skin reaction. Oftentimes it won't be a classic papule the way monkeypox will appear, but the skin will turn red. There may be ulceration and then there'll be a strong reaction. Skin may even break down, and then there may be a scab. And during that period, that's an active immune response, which is good, but it also, because it's a live virus with the ACAM 2000, there can be viral shedding. You don't have that kind of strong reaction with the Jynneos vaccine. It's given intramuscularly, and it tends to be safe and well tolerated. But because it tends to stimulate less of an acute immune response, that's the reason why it's preferred to give 2 doses of that vaccine 4 weeks apart, as opposed to ACAM 2000, which is a one and done vaccine. That's the only advantage of the ACAM 2000 vaccine.
Thank you, Ken. For our concern on materials which monkeypox survives in, how long do you think that the virus will survive on a surface for us to prevent transmission?
I don't know that there's definitive data. I mean, I think the best policy is, the the usual things we do for disinfection. So, alcohol wipes, for example, these kind of things will, degrade the virus. So I would say if there's any concern to try to disinfect, decontaminate, use infection control wherever possible. I don't know that there's been enough studies to be able to say the virus will persist this much. And in terms of persistence, it's a numbers game also. In other words, not every exposure is the same. So if there's a lot more virus on a specific surface, it will tend to persist a bit longer. So I can't give you an absolute threshold, say if it's been 3 days, it's safe, or 4 days, it's safe. I think when in doubt, take appropriate precautions.
Yeah, thank you. That's very much appreciated. So guys, there's no distinct number. It really depends on how much the load of the virus the person used material is concerned about. Last two questions. I think the one is very important. Can breastfeeding women diagnosed with monkeypox be advised to still continue to breastfeed or shift to another form of infant feeding?
That's an excellent question. I don't know the answer to that. I mean, honestly, I don't know if WHO has given specific guidance. I've not seen guidance in the US CDC. I think, till there's specific guidance, I think abundance of caution. But again, to my knowledge, in the current outbreak, there have not been any pregnant women. So I don't know that this issue has come up yet. One thing I would say, I'm not the world's expert on monkeypox. I'm an infectious disease physician in Boston. For those who have serious questions, both the WHO and the CDC have very specific guidance. So instead of just relying on a Facebook webinar, which hopefully is helpful, but I think please go back and look at the WHO and the CDC web pages and keyword monkeypox and go back to it regularly, because this is an evolving epidemic. So unfortunately, there might be more data about breastfeeding down the road. There just isn't any clinical case yet that I'm aware of to be able to inform that discussion.
Thank you for your honesty, Ken. And we do appreciate that this is a rapidly evolving thing. And that question was very significant, even if we don't have any reports of pregnant or breastfeeding women yet. And the last question is, Canada and some European countries are only administering 1 dose of the vaccine to be able to vaccinate more people. Do you think this giving 1 dose is sufficient for achieving full protection, or does missing the second dose after 28 days stand to create some issues?
I don't think we know the answer, but I think it's a pragmatic public health solution. I think the intention of Canada and several of the European countries is that they will give a second dose when there's more vaccine available. But the feeling is that there's some protection that is accrued after a single dose, and they'd rather get more people to have some protection to put a brake on spread. But certainly individuals should be aware about monkeypox and try to modify their behaviors to limit spread, and then getting more people vaccinated. That's another part of the public health strategy.
Oh, that sounds kind of familiar to our initial COVID-19 strategy here in the Philippines before. So as we end this webinar, I'd like to express my deep gratitude to our two resource speakers today, Ken and Desi, and for one last message from you. So the LGBT community is concerned about the stigma and discrimination of monkeypox, especially it being associated with key populations or certain sexual behaviors. What should be our proper messaging for awareness of this disease? Let's start with Dr. Desi, please, as your final take. Des, nakamute ka.
Yeah, I think we have to be aware of the main mode of transmission of monkeypox. And right now, who are the key population affected? It's not that we want to stigmatize certain groups of people, but what we want is to focus our efforts and make sure that the message reaches them and involve them as we try to come up with educational materials and other strategies to minimize the risk and the spread of monkeypox.
Thank you so much for that, Desi and Ken.
I think Dr. Desi really said exactly the right message, which is that the problem is the virus, not the individuals. The fact that we're asking people to consider modifying their behavior is not because we're anti-gay sex or we're not trying to stigmatize people. We're trying to minimize the spread of an infectious agent that has gotten into a community. We think that with people taking individual responsibility with increased global access to vaccines, we can control this epidemic. And I think we all have a part to play.
Thank you so much, guys. Well said. Again, thank you very much for spending your time with us. And let me turn you over now to Rad for our closing.
Okay, so there you go. Thank you very much, Doc Ken. Thank you very much, Doc Desi, for the information that you have shared with us. And I hope that our audience, those who joined us in our FB Live, have learned a lot from this. So once again, good evening, everyone, and thank you very much for joining us. Maraming salamat and magandang gabi sa ating lahat.